It's a great privilege to introduce the next well-known speaker, Professor Neelika Malavige, to our second annual Students Research Session, Faculty of Healthcare Sciences, Eastern University of Sri Lanka. Professor Neelika Malavige is a professor in immunology and head of the Department of Immunology and Molecular Medicine, University of Sri Jayawardenapura. She is the director of Center for Dengue Research at the University of Sri Jayawardenapura. Professor Neelika has been the member of the Executive Committee of International Society for Infectious Diseases since March 2020. Professor Neelika Malavige graduated from the Faculty of Medicine, University of Colombo, and carried out her doctoral studies at the MRC Weatherall Institute of Molecular Medicine, University of Oxford, and has been affiliated to University of Oxford as an academic visitor since then. She was elected as a Fellow of Royal College of Physicians in London and Royal College of Pathologists in 2015. Professor Neelika has done extensive researches related to the dengue, particularly focusing on factors that lead to dengue hemorrhagic fever, identification of biomarkers and mediators of vascular leak in dengue hemorrhagic fever. Her group has identified several mediators that cause vascular leak, and she has headed several clinical trials to determine the efficacy of treatment for dengue fever. Currently, her group is leading in doing PCR for COVID suspected patients and doing research to identify the circulating clades of SARS-CoV2. And she is working on antibody production and involvement of cytokines on the pathogenesis of SARS-CoV2. She has won many awards for research work from National Science Foundation for High Quality Supervision of Research Degrees, Vice Chancellor's Award for the Best Researcher in the University, Zonda Woman of Achievement Award in Field of Medicine, Third World Academy of Science Young Scientist Award in Sri Lanka, the 10 Outstanding Young Persons Award for Medical Research, Sri Lanka Presidential Award, and gold medals for oration from several professional bodies. Today, Professor is going to speak on ending the SARS-CoV-2. Will it be a reality? I'm sure this is the perfect topic for the current pandemic in all over the world, and we got a perfect person to talk about it. Without further delay, I would like to invite Professor Neelika Malavige to deliver her speech. Madam, over to you.
Thank you so much for that very extensive, elaborative introduction. I would like to thank Jana, who is the chairperson of this conference. And I have known Jana for, I think, almost 10 years. She worked with me in our lab. And it's a pleasure to be speaking on Jana's invitation. So without, I'll just get straight to the presentation. Okay, second. Okay, I hope everybody can see my screen. And I'll get my point out. So, okay, yes, so thank you. So everybody this is the talk of the town or talk of the world about how we deal with COVID and when will we get back to normal, getting back to our normal lives. So basically, exactly 1 year ago, we heard about this mysterious pneumonia-like illness that occurred in China. And in January, the first week of January, the first death occurred. And after that, lots of people started dying. And I remember when we were looking at this through staying in Sri Lanka, it looked really scary. And at that moment, I think a lot of us thought that we will not experience this. Oh, poor Chinese people, this is terrible. But of course, it was just a matter of actually weeks when it came to Sri Lanka and is now seen in 212 countries in the world. So Sri Lanka has been very lucky until quite recently. So we did have we did get the first patient in Sri Lanka on the 10th of March, and when we had 60 patients only, Sri Lanka went for a very extensive and a prolonged lockdown of 8 weeks, and even after that, somewhat lockdown period for a even longer duration of time. And we had several clusters. We had the in April we had the CMC cluster in the Colombo municipality area. Then we had the Navy cluster, and then we had these small cluster from people who returned from Middle East. Then, of course, the famous Kandakadu cluster. In the Kandakadu cluster, of course, we saw people infected from all over the country, but it was more or less contained. And then we had a honeymoon period where everybody was happy and back to their normal lives and not the new normal, as we say. And until early October, everybody was having a very good time for 2 months. But then we have this going on now. Suddenly we discovered this large epidemic occurring in a clothing factory in Gampaha. And since then, the number of cases have been increasing, but now it's sort of static with just ups and downs. We are seeing around 500 to some day 800 cases per day, with the PCR capacity of about 14,000. So that's the situation in Sri Lanka now. So will we go back to the honeymoon period where things are no cases in Sri Lanka? Well, I don't think so, but we'll talk about that. So now when we compare Sri Lanka to other countries, now this is as of 6th of December, because every day, you know that things change every day. I mean, Sri Lanka, okay, we do have quite a bit of cases, but I think to compare countries, you have to look at number of cases per million population and number of deaths per million population. So when you compare Sri Lanka to our neighboring countries like India, Bangladesh, and European countries, and even Latin American countries, our mortality rates are good. But of course, countries like Thailand, which is very highly populated, and Taiwan, they have less number of cases, and about 58 to 30 per 1 million, and less death rates also. So I mean, because we are a developing country, you can call it upper or lower middle income, but it's basically lower middle income. We know the very scarcity of resources, and with all the resources we have, I think we should be happy of that we are having things that manage to contain it at this level. Because in this current world, with such an infectious disease, it's impossible to get rid of it. So what I'm going to talk about today is the risk of severe disease or death due to COVID-19, because people want to know, if you get COVID, what are your chances of dying, the antibody responses to COVID, because it's directly related to the vaccines. So now what happens when you get infected? As all of you know, the majority have asymptomatic infection. In other words, they do not show any symptoms at all. They do have the virus inside their bodies, but they're perfectly all right. And we see this for a lot of viral infections like dengue and so on, where you are asymptomatic, but then you transmit. Now, there are other viral infections like herpes, varicella zoster, like chickenpox, and the virus lives in a dormant stage for a long time. But here the virus is not dormant, it is actively replicating and infecting others. So those who get mild infection have a fever, sore throat, muscle pain, tiredness, and cough. I mean, these clinical features we have got all the time for different flus, but the characteristic features are loss of smell and loss of taste that can go on for some time. If you get moderate illness, you do get a pneumonia, and you would need oxygen, but not critical. But if you have severe illness, you get pneumonia, multi-organ failure, thrombosis, all these complications. So then why do you die? Okay, so one thing is because of pneumonia, which is due to acute respiratory distress syndrome. But one of the major causes of death is this thrombosis. So autopsy studies on individuals from people who have died have shown about 50 to 70% of individuals had blood clots forming in their major vessels. So if you have blood clots in your heart, you get a heart attack. If you have blood clots in your brain, you get a stroke. And if you have blood clots in your major arteries, you might get, or even moderate or small capillaries, you can get multi-organ failure. So thrombosis is an important cause of death, and also thrombosis is an important cause of multi-organ failure. The other important cause is sepsis. So you have COVID, and there is a certain degree of immunosuppression also occurring during COVID, because your lymphocyte counts fall, and you have altered immune response, so you're more prone to bacterial infections. So secondary bacterial infections is also an important cause of death. Next, risk of death. Okay, so how likely are you to die if you get COVID? So more, as everybody knows, most young people have no problem. So if we take the young people, so this is from CDC, so if we take the age group between 18 to 29 as a reference group, okay, so this is the comparison group, 18 to 29 years, children from 5 to 17 years have a 16 times less chance of dying, and children, very young children, have 9 times less risk of dying. But as you gradually age, you can see that if you're from 40 to 49, you have a 10 times higher risk than this age group, 18 to 29 age group, of dying. And of course, if you're 75 to 84, you have a 220 times higher risk. And if you're more than 85 years, you have a 630 times higher risk of dying. So this is why all these young people who are listening, if young people are listening, I hope they are, you don't, I mean, you have a social responsibility towards your elder people. You can say, okay, I mean, I get COVID, I mean, what are my chances of dying? Maybe they can be very low, but then you have a responsibility towards the society and the vulnerable individuals to protect them. So the one of the questions that a lot of people are asking are, does South Asian countries have lower mortality rates? Now, this is Italy and France, and everybody knows that even now lots of people are dying in those countries. Yesterday, 3,000 something people have died in USA, but India is right here. So Indian mortality rates are 1.87%, which are on the low side when you compare to other countries. But so we work with quite a lot of, to research with quite a lot of people in India. And they, of course, say that their statistics are quite wrong. So the mortality rates are higher. But even if they're higher, they are not as high as Italy and France and basically Europe and US. So what is special about South Asians? Okay, so what is special is about the age group. So if you have a lot of younger individuals and a less percentage of old individuals, then of course there are less people to die. In other words, so if you look at a country like Italy, about 22.8% are individuals over 65 years. In Sri Lanka, it's half of that amount. And also, we are, if we take individuals over 85 years, in our country, they are less than, very less than if you compare to so many European countries. But if you take India, it's 6.6, and in Bangladesh, even less. And if you look at the median age of the population, that actually gives a very good idea that countries like Italy and Western countries, the median age of the population is much higher than the median age of the population in South Asia. So that is an important factor of the differences in mortality. But then you know that a lot of people in Brazil also died. And when we compare Brazil and Sri Lanka, that is not very different. So let's see. Now, if we look at the mortality rates, now we know that most people die when they're older. So this is, I just want you to look at South Korea, this bottom graph for a minute. So the dark bars are of the proportion of people who died. And you can see the over individuals over 8 years disproportionately died. And basically nobody less than 30 years died in South Korea. So it is, as you age, the mortality rates are higher. But if you look at India, that is not what you see. Okay, I mean, the mortality rates are, you see high mortality rates even in young individuals, 30 to 39, 40 to 49, 50 to 60. And why is this? Why do you have a disproportionately younger individuals dying in India compared to Europe, USA, and South Korea? So even if you look at all the European countries and USA data, it is older people dying, whereas in India and even Bangladesh is relatively younger people. So now that is because there are so many other risk factors of death apart from old age. age is one of the important factors, but then you have other factors like cardiovascular disease, diabetes, respiratory infection, chronic respiratory disease, hypertension, cancer, and of course smoking. Okay, so what makes India and Sri Lanka and the rest of the world different from the rest of the world, and that is diabetes. So if you take India, in the rural areas, the prevalence of diabetes is 3 to 7.8%, and urban areas 10 to 14%. In Sri Lanka, urban areas is 12.8%, and a recent study done in Colombo, aged in over 48, in between 41 to 60-year-olds, it was 36.1% with an overall prevalence of 10.8. Now, if you compare that to other European countries and Italy, they don't have as much as diabetes. I mean, so far less diabetes than Sri Lanka. So this is an important question. Now we are talking about our mortality rates, and I think we have 142 people dead out of almost 30,000 infections. So, but what we need to understand about Sri Lanka is, of those 30 people, now if you take Europe, they only test symptomatic people. So the European numbers in Europe and all other and those European countries are of the symptomatic people. Now in Sri Lanka, we know that those 30,000 or something people include a vast majority of them are asymptomatic, because we test all close contacts. We just test to find every possible positive patient. So of the 30,000 patients we have, not patients, 30,000 positive individuals we have, only about 20% are patients. So a patient by definition is somebody who is ill. So if just because you happen to be infected with a virus, if you are not ill, you are not a patient. So we have, of the 30,000 positive individuals, about only 5,000 are patients. So of the 5,000 so-called patients, we have 142 deaths. So we have to look at our mortality rates in that sense to see whether we have reduced mortality rates. Okay, so the most important question, we've had enough of this. I know every single person has done enough of COVID because of social distancing, dressing up in a new different matter, and because humans crave for human contact. So and of course the economical harm that is happening to our country. So when will we actually see the end of COVID? Now, this is to do with, so let's see what COVID vaccines can do. So now, when we talk about COVID vaccines, now what is the purpose of vaccination? Is it to induce herd immunity versus immunizing the vulnerable and wiping out COVID-19? So if we look at a vaccine like measles, now we know that measles and vaccine is given to all children to completely wipe out measles from the society so that nobody gets infected and there is no measles transmission. But on the other hand, if you take something like influenza, the influenza vaccine is only given to elderly and other people, the vulnerable people who are likely to get severe influenza or die due to influenza. And of course, because the influenza virus changes a bit, and because the immunity to influenza is not long lasting, you give yearly immunization. So for COVID vaccines, what is our aim, or can we achieve our aim, is the other question. So just to talk about herd immunity for anybody who is not familiar with it. So if you have a population and nobody is immune to a particular infection, if you get a few infected individuals, it spreads widely in that population and everybody gets infected. In a population, if you have a few immune people and you get the infection, again, quite a majority of people are infected, but then some people are spared. But let's say you have a immune population, the vast majority of individuals are immune to infection. Even if you get infected individuals coming into the population, because the vast majority are immune, the infection is not transmitted. So this is what is called, and that amount level of immunity or herd immunity that is needed to prevent transmission of infection is different for different viruses. Now this is the R0 value and the herd immunity needed. So R0 value is epidemiological term, which is the number of individuals infected person transmits the infection to. So if you take something like measles is a highly transmissible infection. So each measles infected individual infects 12 to 18 other individuals. But if you take something like H1N1. H1N1 is not as transmissible as measles. So each individual infected with the H1N1 virus infects 1.6%. So you need a herd immunity of only 40% to stop transmission. Whereas if you take measles, you need 92 to 94% of individuals in a community being immune. And where does SARS-CoV2 stand? So it is estimated that the SARS-CoV2 virus infects around 5.7 individuals each. So that is each individual roughly infects 5.7 individuals in the society. So to stop transmission of the SARS-CoV2, you need 82.5% of the individuals being immune. So that's quite a large number of people who need to be immune. Now, if you take states like in certain New York State in US, where there was a very high level of transmission, and after they did the antibodies, they found that the herd immunity was like 15%, nowhere near 82.5%. So by natural infection, it's just that so many people died, but you didn't achieve herd immunity through natural infection. So this is why there's such interest in the vaccine. But can we vaccinate 82.5% of the world population? We know that the world population is 7.6 billion. So let's say 80% of that would be like 5 billion. So can we immunize 5 billion? And if so, how so? That is an important question. So now coming to these COVID vaccines, everybody knows that usually it takes years, so 10 or 15 years or longer to develop a vaccine. That is because you have to have a preclinical stage where you design the vaccine, you have animal studies, then you have a phase 1, which is 1 to 2 years, phase 2, which is usually 2 years, then phase 3, which goes on for 2 to 3 years, collecting all the safety, efficacy data, and then the production happens. So did we take shortcuts as far as COVID is concerned? So now, how many research institutes and vaccine companies manage to do things faster is because they already had done this part and also some of this part. So if you, for example, if I talk about the Oxford vaccine, they already had a adenovirus vaccine construct for the SARS virus, that is the SARS-CoV-1 virus that was there. And they had already done animal studies. So when we got the SARS-CoV-2, instead of the SARS-CoV-1 spike protein, they just inserted the SARS-CoV-2 spike protein for the development of the vaccine. So a lot of other vaccines also had vaccines constructs made. So they just carried out, just changed it slightly. And here what happened was, instead of finishing one phase and going on to the next, a particular phase overlapped with the other. So phase 1 overlapped with phase 2, and then phase 2 overlapped with phase 3. And when phase 3 started, production also started. So when at the end of phase 3, you have enough vaccines, not enough vaccines, but a considerable number of vaccines to immunize people. So that is how the shortcuts were taken. Not a shortcut. I mean, the vaccine procedure was taken, which was not really a shortcut. Now, there are 10 types of vaccines currently undergoing clinical trials and phase 3 clinical trials. And so we have the Oxford vaccine, the Pfizer vaccine, which still hasn't finished the phase 3 clinical trials, although UK started to give it, the Moderna vaccine, 3 Chinese vaccines, and so on. So I'll just briefly describe what these vaccines are. So now so there are 3 leading vaccine candidates currently undergoing phase 3 trials. One of these vaccine candidates, you're very familiar with the platform, which is an inactivated vaccine. Okay, so inactivated vaccine is a formalin inactivated virus, which we see for polio, we see for hepatitis A. So we are very familiar with this platform of vaccine inactivation, and this is the basis for the 3 Chinese vaccines. Then you have this adenovirus vector, which can be a human or a chimpanzee one, depending on the vaccine that is being used. And then you introduce the spike protein, and that is adenovirus vector. So these vaccines have never been used in humans before. Then you have these mRNA vaccines, which contains mRNA, and these type of platforms have also not been used in humans before. So these two platforms are novel platforms which have not been used for human immunization before. So now these are some of the leading vaccines. Pfizer is already being given to individuals in UK high-risk population, and I'll talk about the efficacy. But one disadvantage for countries like ours is these mRNA vaccines need very low temperatures for storage. The Pfizer needs to be stored at -70. The Moderna vaccine at -20, but the vector vaccines which contain adenovirus vector can be stored at the normal fridge temperature, which we are currently using for our vaccine programs. So what is an adenoviral vector? So I'll just briefly talk about this platform for the Oxford vaccine. So here they have taken a chimpanzee adenovirus and inserted the spike protein of the SARS-CoV2. So when you inject the vaccine into a human, the adenovirus, chimpanzee adenovirus, although it's chimpanzee adenovirus, infects the human cells, and the virus proteins are transcribed. So all these adenovirus vaccines are non-replicating. So in other words, the virus does not replicate inside a human. And the Oxford vaccine uses a chimpanzee adenovirus, and that is the important thing, because if you use a human adenovirus, all of us have had several adenoviral infections. So when you immunize somebody with adenovirus, our human immune response, the existing one, can neutralize the vaccine virus, and so the vaccine might not be immunogenic. So having said that, we don't know that the Russian vaccine actually has a human adenovirus platform. So we have to wait and see the efficacy. And in the Moderna vaccine, and it's the same platform in the Pfizer vaccine, is where you have a liposome or a lipid nanoparticle, and the mRNA is inserted to it. And when you inject it, it goes inside the cell, and the mRNA is released, and the mRNA is translated in a ribosome. It makes the spike protein, which is displayed on the cell surface, so antibodies are formed, and is also processed inside the cell to be presented to the T cells, so you get a good T cell response as well. Now, the questions we have about COVID-19 vaccines is, of course, seroconversion, or in other words, becoming a COVID negative to COVID positive with the vaccine. Does that associate with protection? For a lot of vaccines, yes. For mumps, rubella, these vaccines, if you have neutralizing antibodies, you are protected from this virus. But for some vaccines, no. For instance, dengue, even though the dengue vaccines induce neutralizing antibodies, that is not associated with protection from dengue. How long do these antibodies last for? Is it important to develop a T cell response? Now, if you take the chickenpox vaccine, the main component of the immunity to chickenpox driven through that vaccine is mediated by T cells and not antibodies. Whereas if you take the hepatitis B vaccine, antibodies is a major part. Then does the vaccine prevent both mild and severe illness? Does it only prevent severe illness while people still have asymptomatic carrier status, so they keep on transmitting? Do we need yearly booster doses? This is because waning of immunity, we shall talk about, and what are the long-term side effects? So now the antibody responses are important because if these vaccines are inducing antibodies, and if the efficacy is measured by induction of antibodies, it is important to know how long these antibodies last. So this is Sri Lankan data where we looked at neutralizing antibodies in Sri Lankan patients. So the green lines are in patients with mild infection, the red and other colors are patients with mild, moderate and severe illness. So you can see people with mild, moderate and severe illness developed early antibody response compared to some individuals with mild infection where they didn't develop a good neutralizing antibody response even later during illness, possibly because they didn't have much virus to stimulate their immune response in the first place. And when you look at the kinetics of the antibody response, irrespective of disease severity, you can see by most individuals actually develop antibodies as time goes on, but they gradually lose the antibody response with time. So basically, about half of the individuals, 48.5% of individuals become negative for neutralizing antibodies after 90 days. We actually don't know what this means. Whether it means that they're going to be reinfected, we don't know. But of course, reinfection has been documented in other countries. And this is the persistence of antibodies. So this is the same individuals at between at peak 3 to 4 and after 90 days. And in most individuals, we can see that the antibody titers are declining, except for a few individuals. So this paper is currently under review, and you can access it because it's available at a preprint if you want to see more data. So given that these antibody responses, the immunity is waning, so what happens with vaccination? So now the Pfizer vaccine is given to UK individuals. It started yesterday. There were few side effects observed. That's a different story. But basically, based on the data, so this is the data that was submitted to the FDA. So this is the incidence of infection in those who were given the placebo versus those who were given the vaccine. But these have not been published in peer-reviewed journals yet, and the trial is not finished. This is just data of the ongoing trial. And most of the cases, or the majority of the cases, were detected in the placebo, but not in the severe group. There were 10 cases of severe illness in this group, and 9 were in the placebo, but 1 person was in the vaccine group. So it means that some people can get severe disease. So we need more data to see what is going on with the Pfizer vaccine. But of course, when Pfizer announced their results on the 9th of November, 11th of November, the Russia announces that their vaccine is working very well. But their interim analysis was done on 20 patients. So 20 patients is not a huge number to actually analyze data and say how effective it is. And this data, the patients were followed up only for 3 weeks. So we have to wait and see what actually the efficacy rates could be. Then, of course, Moderna came out and said that their vaccine is 94% effective. Their analysis is on 95 cases. Again, not enough, but it's interim analysis. So this data is not enough to actually jump into conclusions. The Oxford vaccine came out and said that their vaccine was either 92 or 62% effective, and that's based on the dosing regime. So the vaccine which was given 2 high doses, the efficacy rate was 62%, whereas when the vaccine was half dose of the vaccine followed by the full dose of the vaccine was given, the efficacy was higher. Again, the trial is ongoing. The safety and efficacy data is not published. Because the trial is not finished. The interim analysis was published yesterday in the Lancet, but again, we need more follow-up because the interim analysis was done in 131 cases. But Oxford is the only vaccine which has actually evaluated the immune responses in individuals over 70 years, who are the individuals who mostly need it, and the immune responses to the Oxford vaccine was similar to that of young individuals. But none of the vaccines, of course, included children. So this is the Chinese vaccine, one of the Chinese vaccines, because it is an inactivated vaccine. So, and this vaccine showed that it's capable of inducing a quick antibody response. So based on it inducing a quick antibody response, there is no efficacy data at all. They believe that it was suitable for emergency use. So because China believed that this because of the quick immune response, it's suitable for emergency use. They have already vaccinated about 1 million people. Apparently, according to the chairman of this company, some people only got mild illness after vaccination, but we actually don't know because data is not available. But although this vaccine induces a quick antibody response, the neutralizing antibodies were less than the other vaccines. So I'll just show that data. So the other vaccines, neutralizing antibodies were in the range of, the titers were in like 1:300. But for this particular vaccine, it was between 1:30 and 1:60, which was significantly less than the neutralizing antibodies generated by the other vaccines. But again, we don't know if it's the neutralizing antibodies that are protective and how much neutralizing antibodies you need to protect somebody from getting COVID. So then if you look at the important question is who gets the vaccine and when. And as we know, we have a population of 7.6 billion individuals. and it is impossible to have manufacture 7.6 doses, actually twice that, because every vaccine needs 2 doses. So it's impossible to manufacture like 15 billion doses of the vaccine within a few months. So which means that only the high-risk people will get it in most countries to start with. I mean, the developed countries will start with the high-risk populations, and then their whole population will get it. In Sri Lanka, I don't know whether we are, it's good or bad, but we are not going to, because we are not going to get the vaccine soon, basically, not at least until June, and mostly not until next September. And through the COVAX agreement, we will be getting around 20% of vaccines, 20% to cover our population, which is for 4.2 million vaccines for population. But all the vaccines may not come at the end of next year. So we don't know. But then we can wait and see what happens in other countries. So I don't know whether it's good or bad. We can observe what the safety data in other countries, and wait for it, because not that we have a choice here. So who gets it and when, of course, depends on who is at more risk and vulnerable, the availability of vaccines and availability of cold storage facilities. So it would be difficult for us to give the Pfizer or Moderna vaccines because it needs very low temperatures for storage. So just to summarize, there are many vaccines undergoing phase 3 clinical trials. Pfizer already being used, authorized to use in the UK. And but of course, these trials are still not finished, and we absolutely need the safety and efficacy data to draw conclusions with the trial data be published in peer-reviewed journals. But again, will the vaccine induce herd immunity and stop transmission? And because of the waning of immunity and the fact that animals also get infected by humans. Now, in the mink farm, I don't know if you know the mink strain of the SARS-CoV2. So in Europe, there are a lot of mink farms to make winter coats. And so the mink in the farms got infected by humans. And then the virus mutated in the minks and reinfected the humans. So when animals can be reinfected with the virus from humans, then it's a little bit of issue when you have a animal reservoir, animals getting infected with human viruses. So lots of questions, of course. So I like to acknowledge everybody in our team who are involved in our research activities, our collaborators from the National Institute of Infectious Diseases, Dr. Anand Eranga, Dr. Damayanti, and Dr. Malika. We are doing a lot of research in the Colombo Municipality Council, and we are very thankful to Dr. Dinu and Dr. Vijayamuni, our collaborators from Oxford, Graham and Tao, and our collaborators from Duke in US. And I would like to thank our funding sources, and thank you for listening.
Thank you, madam. It's very wonderful, elaborative presentation. Now the session is open for the questions. Dear participants, you can send your questions in the chat box, then we can answer. Okay, there is one question, madam, from the participant, Dr. Vishnu. How many times we might get the infection before we get the immunity? Because reinfection is possible, you said. There are cases.
Yeah, there have been cases reported. It's difficult to prove reinfection because the instances where the reinfection was proved is they had the viral sequence of the initial infection, and about 4 months later, when the patient showed symptoms again, they looked at the virus, and because the virus sequence was very much different, then they concluded that it's reinfection. So likewise, there are like about 12-15 reports of confirmed reinfection. But then, but people, of course, because it's difficult to show that sort of evidence, the viral sequence in the first infection and the viral sequence in the subsequent infection, a lot of people don't have that data. But when you talk to people where there is infection, they do talk that people coming back. And in Sri Lanka also, we had this patient in the Colombo municipality area who got an infection in April. And so April was about, I think, 6 months ago, and recently got reinfected again. So I don't think it's a continuation of infection from April to December, because that was actually 7 months ago. So in Sri Lanka also we have a possible reinfection because the person got positive, got symptomatic again recently and was tested positive. Yeah, but people people with severe infection have very high levels of antibodies, moderate and severe. So I don't think they will get reinfected. The people who have got reinfected are those who have had asymptomatic or mild infection. Okay, so there are questions in the chat. I will just.
Yes.
So I just.
There's an appreciation from our dean. Thank you, madam,
Okay.
for your presence and the presentation.
Thank you so. Yeah, question.
Yes. While there are various strains reported, will the current vaccine under trial may benefit different populations from various parts of the world?
Yes, so as far as our population is concerned, we will be benefited because our strain is quite similar to the one that was circulating in Europe and these places. It is not very much different, and it is the spike protein that has been used in these vaccines. So you only want to see the changes in the spike protein. But having said that, certain other strains have emerged in certain countries, which might have issues with the vaccine. So, but when we actually get the vaccine towards the end of next year, maybe August, September next year, we will have to see the viral strains in Sri Lanka, whether there are major changes. So this is why it's important to continuously sequence our viruses to see if we are seeing any differences or changes.
Thank you, madam. Any other questions? Madam, I also have one question. So it's a clinical question. As you mentioned earlier, the most of the time they die due to the pneumonia or due to some kind of thrombosis.
Yes.
And also I heard sometimes these positive patients can get transient hypertension. Because most of the treatment centers, you know that we are not doing any active management or monitoring. We are just observing for them to develop symptoms.
Yes.
Is there any evidence to say that if they will develop transient hypertension before going into the critical phase or something, then we can monitor their blood pressure actively when they get the positive test?
Yeah, so that has not been documented about transient hypertension, and I think there's a good reason for it not being documented.
Yes.
Because in other countries, people go into hospital when they have symptoms. Okay, so this is the important thing. So in other countries, until they actually want to go into hospital, people don't go into hospital, so nobody would be measuring their blood pressure. You see.
Yes. So it's not possible.
Yeah, so in Sri Lanka, we have this habit of sending very healthy people just because they have a virus to treatment centers. That is to, of course, to isolate them from the community and prevent transmission or reduce transmission as much as possible. So then, so in the so-called treatment centers, where actually individuals who are there are not ill, so they don't need treatment in the first place. So maybe, I don't know whether the transient blood pressure is because of, when I hear the stories, a lot of people are under a lot of stress.
Stress, yes.
So yes, so whether that is causing a hypertension, transient hypertension, is the other question.
That's true. So because when they have become positive, we are just sending into like a closed open jail or something like this.
Yes, that is right. Yes.
Everyone is under the very high stress level. That may be the reason.
Yeah. So we don't know. Yeah.
There is no more questions, madam. Thank you very much for the wonderful presentation.
Okay, my pleasure.
And thank you very much.
Thank you. My pleasure.